Welcome to the presentation on clot prevention. In this presentation, we will first cover the major causes of clots and where they are commonly located. Then we will cover common classes of medications used for clot prevention, and then end the presentation with some additional resources. There are three major reasons for clots to occur: hypercoagulability, vessel wall injury, and changes to blood flow. Hypercoagulability means the blood is in an abnormal state that is more likely to clot. Reasons for the hypercoagulable state may be genetic mutations or autoimmune diseases. In instances in vessel wall injury, the body creates a clot at the site of injury to protect itself during trauma, surgery, or infections. And finally, decreases in blood flow cause the cells to pool and stick together, resulting in clot formation. This often happens in cases of atrial fibrillation, heart failure, and long airplane flights or car rides. Blood clots can result from any of these causes alone or in combination with one another. Virchow's triad is a common representation of the three major areas of clot formation. Rudolf Virchow, who described these causes of clots, was a German pathologist over 150 years ago. Doctors still use this triad today to help them remember the causes or risk factors for clotting. Blood clots may cause a variety of complications. These include a myocardial infarction, or MI, commonly referred to as a heart attack, a pulmonary embolism, or PE, a deep vein thrombosis, which is a DVT occurring in the peripheral blood vessels, and finally ischemic stroke. As you can see, clots primarily affect the heart, lungs, legs, or brain. These are the different classes of agents used to prevent clot formation. The first, and most common, is warfarin, which goes by the brand name Coumadin or Jantoven. Then we have newer agents like Xarelto and Eliquis, both of which are direct factor Xa inhibitors, and Pradaxa, which is a direct thrombin inhibitor. Aspirin is also used for clot prevention, and then we'll also discuss a few other anticoagulants used for clot prevention as well. This is a busy slide, and you do not need to spend time in the details or trying to memorize it. It's just here for your information. So this is the image of the clotting cascade. It shows many different pathways and factors that cause clot formation. This clotting cascade is natural within our body to form clots when it is helpful to our body, such as if we cut our finger and we need to stop bleeding. However, this cascade can sometimes be triggered on accident and cause clots when we don't want them. We will be reviewing several drugs that target different factors along this clotting cascades to help prevent clotting from occurring. So now for a little history lesson. In the 1920s, farmers had noticed that their cattle were dying from hemorrhage after minor procedures. They found out that this bleeding was contributed to by their consumption of spoiled sweet clover. So the sweet clover contained a compound called coumarin, which is a natural substance found in many plants, and during the decomposition of the sweet clover, it becomes dicoumarol, which is a naturally occurring anticoagulant. So then in the 1940s, this dicoumarol was marketed as a potent rodenticide, and then it was approved for medicinal use in humans in the 1950s for the prevention of clots. For human use, this compound is marketed under the brand name Coumadin or Jantoven with the generic name warfarin. Warfarin works by inhibiting the formation of vitamin K-dependent clotting factors within the liver. It is used for stroke and MI prevention, as well as DVT and PE treatment and prevention. So now, going back to our clotting cascade, wherever you see vitamin K on this diagram, that is where warfarin acts to prevent clot formation. Unsurprisingly, the main adverse effect of warfarin is bleeding. Patients on warfarin must have their INR monitored regularly. An INR is a measurement of how long it takes blood to clot. Vitamin K antagonists may also cause necrosis of the skin and other tissues, referred to as purple toe syndrome. It is also contraindicated for use in pregnancy. And then importantly, vitamin K antagonists have many major drug interactions, so it's important to pay attention to all medications when patients are taking warfarin. Patients on warfarin require specific dosing and intense monitoring to make sure they are within their goal range for their INR. The goal for the INR depends on the indication. So a typical goal for a patient with AFib or VTE is between 2 and 3. Those using warfarin for mechanical valve replacement, the goal is between 2.5 and 3.5. Most of your patients are going to have a typical goal between 2 and 3. Patients may need their dose adjusted to reach this goal. Having the goal INR is important to manage both the risks and the benefits of being on warfarin therapy. If the INR is too low, the clotting time is too short and the patient is now at a risk of clotting. If the INR is too high, clotting time is too high, meaning there's a risk of bleed. The purpose of the goal, again, is to manage the risk of bleeding with the benefit of clot prevention. Patients are started on a typical starting dose, monitored weekly until the INR is stable, and then monthly after, as long as they remain in that goal range. Patients must also be monitored for the occurrence of thromboembolism, which is stroke or VTE, which is what we are trying to prevent. Also, make sure to monitor patients for bleeding and excessive bruising. As you can see, warfarin patients must be monitored for a number of safety concerns. This is why we're following their INR so closely. If the INR is too high, vitamin K can be used as an antidote to reverse the effects of warfarin. Patients should monitor for signs and symptoms of bleeding, such as bleeding gums, blood in the stool, as well as coffee ground-like stools, which is indicative of an intestinal bleed. We must also pay attention to drug interactions, as mentioned previously, especially dietary supplements. Patients should always ask their pharmacist or physician before starting a new medication or supplement. You will not be expected to know all of the drug interactions, but when you see a vitamin K antagonist such as warfarin, think about drug interactions and make sure to consult the pharmacist with a new medication, over-the-counter herbal supplement when they're either started or stopped on those medications. Antibiotics are also one of the most common interactions that we see with warfarin. The INR may need to be monitored more closely when these medications are started or discontinued, and we can adjust the dose if needed. Most drug interactions increase the INR, but there are a few that decrease the INR. Also, dietary consumption of vitamin K is of great concern for these patients as well. Overall, patient education is incredibly important for patients on warfarin, and we'll talk a little bit more about the key points for education on the next slide. Unfortunately, a variety of foods contain high amounts of vitamin K. As a general rule, green leafy vegetables are an example of a food that is vitamin K rich. Green tea and multivitamins also tend to have vitamin K as well. As a general rule, patients must be consistent with their vitamin K intake. Providers can adjust the warfarin dose to counteract any dietary intake of vitamin K. But again, the patient must be consistent. For example, if a patient usually eats spinach every day and then stops eating spinach, their INR may go up. For this course, you should know how vitamin K affects the INR. More vitamin K decreases the INR. Less vitamin K increases the INR. Alcohol also affects the INR. So acute drinking decreases the metabolism of the vitamin K antagonist, which increases the INR and increases the risk of bleed. Chronic alcohol use has the opposite effect. So people that have problems with alcoholism will clot more easily. It is best for patients to avoid alcohol completely if possible, including any alcohol that may be obtained in OTC products such as cough syrups. Remember, patients need regular blood monitoring so the doses can be adjusted accordingly so they can remain within that goal. Sally is a 56-year-old female with atrial fibrillation. She takes warfarin every evening with dinner. Sally visits a local anticoagulation clinic as needed for monitoring her INR. Today in clinic, Sally's blood is too thin. Which of the following recent changes may have caused her blood to be too thin? A large spinach salad, 2 missed warfarin doses this week, 3 glasses of wine last evening, or a large glass of water this morning. I'm not going to provide the answer at this time. I encourage you to review the information we've gone over so far in this presentation, or discuss the question online in the discussion boards if the answer is not clear to you. Now switching gears to some newer agents. Dabigatran, or Pradaxa, is the first new oral anticoagulant in over 50 years. It's a direct thrombin inhibitor which prevents platelet aggregation. It's indicated for thromboembolism prevention and VTE prophylaxis post-hip or knee replacement. Unlike warfarin, Pradaxa does not need anticoagulant monitoring or frequent dose adjustments, and it has fewer drug and food interactions than warfarin as well. Dabigatran also prevents more strokes when compared to warfarin, including hemorrhagic strokes. In fact, dabigatran prevents about 5 more strokes for every 1,000 AFib patients that are treated for 1 year compared to warfarin therapy. But don't shut the doors of your anti-coag clinic just yet. Unfortunately, Pradaxa costs about $8 a day, which is much more than the cost of warfarin, even the cost of warfarin plus the monitoring warfarin requires. Dabigatran must also be taken twice daily, unlike once daily with warfarin. And Pradaxa isn't reversible, which is a major safety concern. Finally, dabigatran causes more dyspepsia than warfarin as well. However, both drugs do have a similar overall bleeding risk. Warfarin appears to cause more intracranial bleeding, but dabigatran causes more GI bleeding. We might suggest dabigatran for when warfarin monitoring isn't an option or for patients with poor INR control. We would not recommend routinely switching patients to dabigatran if they're doing well on warfarin already. So obviously some common adverse effects of dabigatran would be bleeding. If this medication is stopped for any reason other than bleeding, make sure to start them on another anticoagulant. Surgery and procedures are precautions for use for dabigatran, obviously because of the bleed risk, and therapy must be stopped prior to the surgery or the procedure. Renal dysfunction is also a precaution for use, and depending on the severity of the renal dysfunction, we may need to adjust the dose or not use at all. Rivaroxaban, or Xarelto, and apixaban, or Eliquis, both inhibit factor Xa and prothrombinase activity. They have no direct effect on platelet aggregation, but indirectly inhibit platelet aggregation induced by thrombin. By inhibiting factor Xa, these medications decrease thrombin generation. Factor Xa inhibitors are indicated for stroke risk reduction in non-valvular AFib, DVT and PE treatment, including the recurrence of DVT or PE, as well as DVT prophylaxis after knee or hip replacement surgery. Eliquis and Xarelto are both oral formulations. Another factor Xa inhibitor, fondaparinux, is administered sub-Q, and this is used as a bridging agent to prevent acute VTE while starting warfarin or during procedures. We'll talk about fondaparinux a little bit later. Like dabigatran, factor Xa inhibitors also require no INR monitoring, but again, they don't have an antidote either, so this is a safety concern as well. Again, common adverse effects are bleeding, and these are also to be used in caution with cases of renal dysfunction. There are also a few box warnings for factor Xa inhibitors, including increased risk of epidural or spinal hematoma during certain procedures, which may cause subsequent paralysis. There are also a number of injectable anticoagulants, including heparin, enoxaparin or Lovenox, and then fondaparinux or Rixtra. These medications tend to work quickly and also have a short half-life, so they leave the system much faster than other agents. They're often used in short-term situations, such as when a patient will be bedbound in the hospital. They can also be used as bridging therapy, which I mentioned on the previous slide, to get the patient covered with anticoagulation until the warfarin starts working. Again, their main adverse effect is a risk for potential over-anticoagulation leading to an active bleed. Unfractionated heparin and low molecular weight heparin are the preferred agents during pregnancy. This is because these molecules are much too big to cross the placenta, so therefore there is no theoretical risk for the fetus. Also used for clot prevention. It's abbreviated as ASA for its full name, acetylsalicylic acid, as you can see on the slide. It's commonly used for its abilities to prevent clots by irreversibly inhibiting both the COX-1 and COX-2 enzymes that are responsible for platelet aggregation. It was originally designed to be used for pain, inflammation, and fever. However, due to its side effects, aspirin is only recommended for primary and secondary prevention of ischemia. It's important to note that NSAIDs, like ibuprofen and naproxen, reversibly inhibit COX-1 and COX-2 enzymes, so these medications may interact with the clot-preventing effects of aspirin when they're used together. Like all other agents in this presentation, bleeding is a common adverse effect of aspirin. Also, aspirin may cause GI effects, including potential for ulcer. Rare but serious side effects include tinnitus, or ringing in the ear, and metabolic acidosis. Aspirin use is contraindicated in bleeding disorders, children younger than 16 years old due to its potential for Reye syndrome, as well as patients who are pregnant. The final class of agents we will cover in this presentation are platelet aggregation inhibitors. These include Plavix or clopidogrel, Effient or prasugrel, and Brilinta or ticagrelor. These agents are used to prevent thrombotic events associated with myocardial infarction, cardiovascular accident, peripheral artery disease, and angina. They are also used during percutaneous intervention or stent placement. These agents are all available in oral formulations. Like all the other agents in this presentation, platelet aggregation inhibitors also cause an increased risk of bleed. They may also cause some GI upset and rarely cause neutropenia. Unfortunately, there are some drug interactions with clopidogrel, so it is important to keep that in mind for our patients. Finally, like the other agents, these medications must be discontinued for certain surgeries and procedures and are also contraindicated in cases of active bleed. In summary, all of these agents, because they are used to prevent clot formation, increase the risk of bleed. For warfarin, patient education is key. Remember to discuss dietary restrictions, alcohol use, and regular monitoring of INR with patients on warfarin. Remember, there are many different agents that prevent clots, but they all work a little bit differently and therefore have different monitoring parameters and educational points. Overall, anticoagulation is very complex and must be individualized to each patient based on a number of different factors.